Hello, my name is John Carethers. I'm a professor at the University of Michigan. Thank you for having me at your Hereditary Cancer Conference today. I'm going to talk to you about strategies in bypassing barriers for colorectal cancer screening, prevention, and genetic testing. My disclosures that I have NIH and University of Michigan funding, and I'm a board director at Vantor, a life sciences supply company, has no relation to what I'm talking about today. Here's my outline today. I'm going to talk briefly about gene-environmental interactions for colorectal cancer development and follow that up with some brief epidemiology and root causes for colorectal cancer disparities, talk about some screening approaches for colon cancer and high-risk patients and genetic counseling and testing, and then close with mitigating barriers to get screened or surveyed. So cancer develops from gene-environmental interaction. You have a genetically susceptible individual who may overwhelmingly have genetic susceptibility by an inherited germline mutation, or it can be without a germline mutation and based on their genetic makeup. Sometimes we call single nucleotide polymorphisms that collectively may give it a disadvantage or risk. You are exposed throughout your lifetime to a number of different environmental causes for cancer. Here are some examples here. For instance, we know HPV could be a high risk for cervical head and neck, as well as anal cancer, and HBV, hepatitis B virus, for liver cancer. We know about UV exposure in skin. Tobacco can provide increased risk for lung cancer, head and neck cancers, colon cancers, etc. But more importantly, for the GI tract tumors, high-fat diet and inflammation can lead to several colon and gastric tumors, as well as breast and stomach tumors as well. So this is the combination of this genetically susceptible individual, all of us, and that environmental exposure can increase your risk for cancer. Looking at this a different way is we can break this down to non-modifiable risk factors and modifiable risk factors. Those non-modifiable risk factors are your genetic susceptibility, whether you have a germline with high or low risk alleles, or the right background genetic makeup, which can be involved with your race or ethnicity. Another non-modifiable risk factor is your age. The things that are modifiable include the things in the environment, the type of diet or supplements, or your gut microbiome makeup, use of tobacco, use of non-steroidal anti-inflammatory agents, hormone replacement therapy, or physical activity. On top of that, for colon cancer, a modifiable risk factor is your ability to screen for cancer. And those two combined give you your ultimate colorectal cancer risk in the long term over a lifetime. If you look at this from a standpoint of a model for development of cancer, again, hitting this idea of having genetic plus environmental factors for that interaction determines your risk. In classic sporadic cancer, it takes 3 to 5 decades for you to develop an adenoma, and we know about 25% of people by the time age 50 will have an adenoma. But most of those adenomas do not progress, but some will, and that may take another 1 to 2 decades to give you that 5 to 6% risk. You know, when you have a genetically inherited condition such as familial adenomatous polyposis or Lynch syndrome, different parts of the tumor spectrum are accelerated. An FAP with mutation in the germline APC gene, polyps are initiated much earlier, but the time for polyps to cancer is similar to sporadic, even though you have 100% risk for developing colon cancer. Lynch syndrome, the tumor initiation is normal, but the passage from adenoma to cancer is accelerated, giving you, again, a high risk. In any of these conditions, sporadic or a germline inherited mutation, different things from the environment, I list here microbiome and inflammation, can influence any step of going from a normal germ cell colonocyte to tumor initiation with an adenoma, tumor progression to dysplasia or cancer. And this gives variability in the outcome of these patients. For instance, not every FAP patient will get a colon cancer by 40. Some may be 50 or 60. Again, not every Lynch patient will get a cancer by age 40 or 50. And this can be due to a number of different effects, also including genetics, but certainly the environment can play a role in modifying the time and risk for those cancers. Let me move to epidemiology and root causes. So colorectal cancer is very common in the United States. It is the overall second leading cause of cancer with men and women overall. The incidence is different based on your race and ethnicity background. So here, this is data from the Colorectal Cancer Alliances showing the incidence overall, as well as for male and female. And just looking at overall, with a rate of 36.9 per 100,000 based on the 2000 census, the highest rate overall for incidence of cancer is with non-Hispanic Blacks at a rate of 43.6 per 100,000. The next highest is American Indians or Native Americans at 42.3 per 100,000. By the way, the rate for American Indians has gone up dramatically because their lifespan has accelerated. This is really high for males in Blacks and highest for female amongst American Indians. If you look at deaths from that, overall, the highest is 18.5 per 100,000 in non-Hispanic Blacks, and that remains high for both males and females of that particular race. So there is a disparity for incidence that leans toward Blacks and Native Americans for incidence, and for deaths for Blacks overall. These are trends taken from SEER data, just published this year in an article I wrote for Advances in Cancer Research, showing that the incidence rates have come down for most races. Purple here, light purple, shows Black patients, which is still elevated above all other races. You see in blue the data for American Indians, which has been relatively level overall, and now is the second highest rates secondary to Blacks for incidence. For mortality, similar pattern. You see Blacks in purple. They've also come down compared to other races, but they still remain higher at the end of 2018-2019, where this data was collected. And you look at the data for American Indians, relatively slight decrease, but the slope is much slower. Now the second highest cause of mortality amongst the races and ethnicities in the United States. This is colon cancer survival, which tells a slightly different story. This data shows whites in green, all races in red, and Blacks, which most of the data is for, are lags behind percent people survive from colon cancer overall for all stages. So there, again, there's a disparity in incidence, deaths, as well as survival. That disparity is seen acutely amongst Black patients. In one way to think about this is a depiction I published a few years ago showing compared to white patients, there is a shift in the age of the colorectal cancer curve for Blacks. So if you look at when screening started at age 50, and there's some data that we're moving to age 45 now, approximately data from 20 years ago showed that 5.5% of whites would have colon cancer under the age of 50, where 94.5% of all colon cancers would be over the age of 50. And this is the reason why originally age 50 was selected to start colorectal cancer screening. But if you looked at Blacks, double the rate of patients at age 50 or under had colon cancer. If Black patients were moved to age 45, as has been recommended for 20 years the rate would approximate that of whites with 5% under the age 50. I'll make a couple other points here. Blacks typically present 0 to 8 years younger than colorectal cancer than whites. That is data from a number of different studies. It also implies that the precursors to cancer are initiated slightly earlier. And there's less time from age 50 because they present earlier to the average age of colorectal cancer screening, shortening the window for screening intervention. And it may help drive some of that disparity. This is a fascinating study by a colleague, Steve O'Keefe, published in Nature Communication 2015, where he did quick diet exchanges between rural Africans and African Americans. What he did is he took mucosa biopsies before the diet exchange and after the diet exchange, excuse me, and looked at a number of different parameters that would assess the degree of risk for proliferation in the colon. And he took rural Africans who were normally on this legume and rice diet and fed a high-fat, low-fiber, westernized style diet. And the African Americans, he gave this rural African diet. And what he noticed was incredible 2-week changes, reciprocal changes in mucosa biomarkers. If you look on the left here, Ki67 stands for the proliferation of the colonic cells. More proliferation would mean higher risk for mutation and subsequent growth. And you can see the African Americans who switched to the rural African diet had half the rate of proliferation compared to before the diet exchange. And Africans on the westernized diet had double the rate of proliferation. In the bottom 2 bar graphs here, it shows the level of intraepithelial lymphocytes and CD68 inflammatory markers. The bottom line is that the African Americans on the rural African diet had lower inflammation, and the Africans on the westernized diet had increased inflammation. Finally, in looking at 2 outcomes, 2 chemical outcomes, a short chain fatty acid we call butyrate, shows that butyrate is a fuel for normal colonocytes, and the more the better. And the African Americans had increase on the rural African diet, whereas the Africans on the westernized diet had decrease in butyrate, as well as looking at a secondary bile acid, which tends to be a little bit more pro-carcinogenic. The African Americans on the rural African diet had lower of the secondary bile acid, and the opposite was for the rural Africans on the westernized diet. So the bottom line is, even after 2 weeks, there was changes in the behavior of the colon. And you could imagine on a lifetime of diet, having these persistent changes can alter the way the colon risk is for colon cancer. Now we know that colon cancer, for the most part, develops over time from an adenoma all the way to carcinoma. And this is depicted in this model, showing a small adenoma, and if it's left undetected, and for some, will grow, develop dysplasia, develop carcinoma, and then invasive cancer. And these are some endoscopic pictures of adenomas as well as cancer. Now, those adenomas, those precursors, the real question is, we see these disparities, particularly for African Americans and Native Americans. Does that hold up with adenomas? The answer is yes. This is a very large study out of Kaiser Permanente looking at screening colonoscopy. And we do know that men tend to have higher rates of colonic adenomas, 1.77 compared to women. And the older you are, the higher risk for adenomas goes up. As you can see, the relative risk goes from 1.26 from 55 to 59, all the way essentially over 2 once you get above age 70 without the intervening colonoscopies. If you look at race, taking whites as 1, Blacks had a 15% higher risk overall for having high-risk adenomas, as did Native Americans at 48% increased risk, and that varied between whether you're a woman or a male. Another thing to show is that the site of the adenoma is different and puts you at different risk. The reason why this is important is because right-sided or proximal adenomas in cancers are slightly harder to detect, even at the best test, which is colonoscopy. And you can see for any proximal adenoma, using whites as 1.0, blacks had a 26% increased risk for proximal adenomas, and Native Americans had 55% increase for proximal adenomas, which are harder to detect. This was not the specific case for distal adenomas for blacks with a 9% increase, while Native Americans had a 47% increase. So Native Americans had a higher risk for some of these high-risk adenomas. So just to summarize that piece, there's increased right-sided prevalence in African Americans and Native Americans. Colonoscopy is not as effective in reducing mortality on right-sided lesions. There's a number of studies that show that. The combination could amplify the magnitude of the disparity with any condition with excess right-sided cancers. And one of the most highest risk adenoma or polyp is the sessile serrated adenoma, but there's very little data on that. One study that showed that there was no real difference between whites and blacks in the rates of those. Other studies suggest there's a slight increase from there. Now, what's the real driver for this? Is it just because you're black or white or Native American? Unlikely. Most of these things are determined by the environment, and the environment is determined by your socioeconomic condition. And so this is a diagram I made for the recent article I wrote. In reality, if you look at poor people, even in Appalachia, their risk is increased for colorectal cancer. So there's a level of socioeconomic inequality, and where you have a lower socioeconomic status, a low level of education, and may have more difficult access to healthcare. And that leads to downstream consequences, because your socioeconomic status determines what neighborhood you live in, the type of job you hold, whether you live in an area where there's grocery store deserts, don't have access to fresh fruit and vegetables. In other words, have only access to canned or high-fat foods. Your diet tends to be different. You have easier access and more use of tobacco and alcohol in some of these neighborhoods. You may not have the same level of parks in these neighborhoods, and so there's lower physical activity. And there may be difficult with preventive medicine as well. That has metabolic consequences that changes the local environment of colon, alterations of the gut microbiome, increases localized inflammation, compromises immunity. And that has biological consequences, as I showed you in that one article with the diet swap: increased colonic inflammation, increase in earlier adenoma formation, developing subsequent somatic gene mutations, and increasing your risk for colorectal cancer as you age. So this is not really necessarily a race or ethnicity. It's really a socioeconomic reality over a lifetime. Let me talk to you about colorectal cancer screening approaches. Screening for colorectal cancers is highly important in the United States. In the United States, there are about 150,000 cases of colorectal cancer each year, 52,000 and some change deaths. So colon cancer incidence is not the highest of all incidents, but it is the highest rate of deaths for these 4 cancers I list here. And we've invented multiple tests to screen for this because of the high death rate. These are broken down into tiers. The most common and first tier are fecal immunochemical testing. These are cards, as well as colonoscopy. Second tier, you start getting into stool DNA tests, CT colonography, and flexible sigmoidoscopy, etc. Relatively obsolete is the old fecal occult blood testing, as well as barium enema now. Colorectal cancer screening strategies are using those tiered tests. Colonoscopy has been most common in the United States. The interval is about every 10 years. Finding significant lesions with tandem colonoscopy studies show it could be up to 97% effective. It is not only diagnostic, it's therapeutic, but it requires anesthesia prep, and there's a perforation risk. And for those with high-risk conditions or who previously had cancer polyps, it is the only modality for surveillance. If you have FAP, if you have Lynch, colonoscopy is the only modality you should be using. CT colonography is diagnostic only. Of course, if it's positive, it requires colonoscopy, but it can pick up a number of significant lesions similar to colonoscopy. We have flexible sigmoidoscopy used with or without combination of occult blood tests, enema, FIT, as well as stool DNA tests. You see the range of detection of significant lesions. The highest seems to be the stool DNA test, but I mentioned that they are combined with FIT, so it's really a FIT plus another test. If any of these are positive, it requires a colonoscopy for further evaluation. That's why many people in the United States have gone straight to colonoscopy because it's diagnostic and therapeutic. Colorectal cancer screening in the United States has gone up dramatically. You can see in the chart on the left chart here, showing by 2018, 61%, and certainly by 2020, 65% of whites and 62% of blacks have been screened by a colonoscopy. And you also see in the red line here that the incident rates of colon cancer has gone down. That incident rates is true for both blacks and whites, showing here in this middle graph that the rates have dropped for both blacks and whites. However, there is still a gap between the incidence between blacks and whites, shown by this big arrow, as well as the mortality. So there's still a disparity. And you can see the black-white mortality rate ratio, where one would be equal between the two races, actually climbed over time and seems to be leveling off in recent years. Let me go to high-risk patients and genetic counseling and testing. So we know that family history is very important for high-risk conditions. If you look at this table that I made a few years ago, the average risk in the United States is around 5 to 6%. That's people with no family history. But if you have a first-degree relative, that's mom, dad, brother, sister, any age with an adenoma or cancer. Again, adenomas are precursor to cancer, as well as some of cancer. You double that risk to about 10%. So keep in mind, adenomas, the classic adenoma gives you the same risk as a colon cancer with a first-degree relative. If you have two second-degree relatives with any age colorectal cancer or a first-degree relative who's less than 60, even with an adenoma, you triple that risk from the normal. And if you have someone who's really young at less than 45, you raise that risk 6 times normal. And of course, if you have Lynch or FAP, you get near uniform risk of colon cancer in your lifetime. Now, I work at the University of Michigan. We run a cancer genetics clinic, and our modus operandus is to do genetic counseling and then consider comprehensive genetic testing, evaluation, surveillance. We have a multidisciplinary clinic with experts from a variety of different backgrounds, and we look at all cancer syndromes. These include colorectal polyposis, hereditary gastric, pancreatic, HBOC, hereditary breast and ovarian, endometrial, endocrine, etc., that we do in this multidisciplinary clinic. Our approach is to take a complete family history, look at all the reports, and then provide genetic counseling with the patient understanding those risks and benefits, do the appropriate and confidential genetic testing. We interpret the tests, and then may provide genetic counseling to other family members, and then do targeted genetic testing depending on the results of that test for appropriate surveillance or therapy. Some of our approach would say that there's no testing or do an appropriate testing depending on the person. We may do individual gene testing. Usually that's its follow-up. Most commonly right now is multiplex panel testing, but we have done some whole exome and whole genome testing, which will probably become the standard in the future. The benefits and limitations of genetic testing. The benefits identify the syndrome genetically and can lead to other interventions that prevent cancer or detect it. It gives information for the healthcare of that particular person as well as family members, and can alleviate uncertainty and anxiety. But it also has limitations because a negative test may not totally eliminate the person or the family unless there's a known mutation in the family. And there's some genetic variants of unknown clinical significance, we call VUSs, variants of unknown significance, that we may not be able to tell if it's certainly pathogenic or not. Now, speaking, since the theme here has to do with disparities, are there differences between genetic testing amongst races? Well, I can tell you, particularly for FAP and Lynch and most of the other large number of hereditary syndromes, those syndromes appear in almost every race. I have seen Black patients, Native American patients, etc., with Lynch, in addition to white patients. So those have permeated race. There are some founder mutations in certain groups, but the disease has permeated in essentially every race. Are there differences in the type of germline mutation? Well, the most comprehensive study was on Lynch family by Sonia Kupfer's group at the University of Chicago, published in 2015. They looked at African-American Lynch families, and instead of just about 50% in white patients are MLH1, 2/3 of mutations in African-American were MLH1, and there were some novel mutations, but the cumulative risk for cancer was very similar to anyone from a European descent, and it just shows the genetic diversity with the mutation spectrum. So what that means is it's the same genes involved, although there might be some unique mutations that might segregate to certain races or ethnicities. What about somatic mutations? So these are mutations found within the tumor. There's this one paper that was published in PNAS a few years ago, which showed specific mutations in EPHA6 and FLCN were found exclusively in some African-American colorectal cancers as possible driver genes, but that hasn't been reproduced in another study just yet. Are there disparities in assessing for testing in hereditary colon cancer syndromes? There's some data out there, and this is two papers recently published. One is looking at the rates of complete family history. So if you were Black, about just under 14% had a complete family history compared to whites, but 22% had a complete family history in the medical record, and that was significantly different. If you looked at the rates of genetic referrals, so this is not testing, but referrals, there was a trend, but not significant, for less referrals for Black patients at 19.45%, excuse me, compared to white patients, 27.6% for referrals. So there may be some underlying bias, but that didn't reach significance in this particular study. Another thing is that there was a lower diagnostic yield and a higher variant of uncertain significant rate in Hispanics, African and Pacific Islanders compared to European ancestry, meaning that the diagnostic yield for some of these races and ethnicity was not the same as those from European ancestry. That is largely because most of the studies that have been done have been on European ancestry patients, and there could be other unknown variants in some of these other races and ethnicities that just haven't been characterized. So let me close by telling you some mitigating barriers to get screened or surveyed. So this is the general guidelines to screening for and surveillance in colorectal cancer in the United States. Men or women, if they're symptomatic, they should get a diagnostic workup. That is not screening. But if they're asymptomatic and they're age 50, and I will count that this is moving to age 45 by recent data by the U.S. Preventive Services Task Force and recommendations, and if you have a negative family history, that is average risk, where tier 1 tests are preferred. Those are FIT and colonoscopy. If you, by the way, July 2017 was the first time there was race considered in any of the guidelines, and they recommend the move, a qualified movement to age 45 for African Americans. But this is moving, all races are moving at 45. If you have a positive family history, particularly of Lynch or FAP, that's genetic counseling and surveillance. If you don't fit those categories, if you have a first-degree relative affected that's greater than 60 years, then screening should begin at age 40. That's usually 10 years before age 50. The recommendations have not moved it under 40 yet. Since the regular screen went from 50 to 45, with this move from 45 to 35, that has not been recommended yet. It's still at 40. If you have 2 or more first-degree relatives and someone under age 50, it's still 40 right now. And those tests should be colonoscopy because of the high risk for the family history. Now, what about testing in marginalized groups? So the Affordable Care Act, which was acted in 2010 under President Obama, for colorectal cancer, most insurance plans must cover colorectal cancer for persons that at the time it was 50 to age 75, okay? The Affordable Care Act website does not list specific colorectal diagnostic interventions, but the U.S. Preventive Services Task Force recommends these tests, which most people in the United States would do colonoscopy. And remember, this is 2010, so we've replaced FIT for fecal occult blood test. But there was no Affordable Care Act policy for Lynch or other hereditary cancer coverages. So that is a gap. So this is a paper that's in press from a Journal of Cancer Policy, looking at individuals and families at risk for hereditary non-polyposis cancer or Lynch syndrome. So the ACA just limited those for 50 or older. Lynch syndrome was not covered by the ACA, but there's a number of organizations that are advocating for this. I will point out some other things from this action network. For race and minority health, trying to connect the underserved with available services. Women's health, particularly BRCA1 and 2 is not tested in all states. And I see FORCE is behind some of the advocacy for that. And also HBOC and men's health. Men are not covered for BRCA1 and 2 testing under the Affordable Care Act, which leave in a gap, because I just saw a male just last week who has a BRCA2 mutation and is at risk. So this is a gap, in particular those who are not insured. What are some strategies to reduce disparity, particularly for African Americans? The biggest study, there's a number of things listed here: patient education, physician education. Believe it or not, some physicians have no knowledge of these disparities. Changing the age, that has just changed to 45, et cetera. But one of the biggest and best studied is patient navigation. Now, let me show you the classic study that used this. This is the Delaware Cancer Consortium, which was funded through the state of Delaware. Colonoscopy was preferred. They did 10,000 navigations over essentially a 9-year period from 2001 to 2009. And looking at this left graph here, in 2001 when they started, you can see the breakdown of local was 15% of cancers found, regional was 56%, distal was 23%. With the patient navigation and using colonoscopy, 9 years later, the amount of local cancer jumped from 15 to 50%, regional dropped from 56 to 33%, meaning that screening was finding things at an earlier stage where it's curable. Now look at the difference between incidence and mortality amongst races. This was comparing Blacks and whites. If you look at the beginning of the study, you can see that white Americans had a colon cancer rate of about 60 per 100,000, and African Americans was about 68 per 100,000. Over time, with navigations, 2 things happen. The incidence for both whites and Blacks went down, both whites and Blacks, but the Black rate dropped such that the incidence at the end of the study, there was no disparity. the incidence was exactly the same. So African Americans went from 47.8% screened in 2001 to 73.5% screened in 2009. And whites went from 58% screening in 2001 to 74.7% in 2009. So 74% essentially for both blacks and whites getting screened, with the incidence removing the disparity at the end of the study. Mortality, which tends to lag behind incidence, shows that the mortality rates also drop for both races, but drop faster for blacks. For whites, 19.45 per 100,000 down to 16.94 per 100,000. And blacks went from 31.27 per 100,000 to 18.35 per 100,000. What this means is that screening, and particularly with navigation, can eliminate the disparity. It's the great equalizer. Now, there's some similarities between cancer disparities and what has happened with COVID-19. We, of course, know that colorectal cancer is really a genetic disease, local environment influences, onset is over months to years, and asymptomatic screening is part of routine healthcare. COVID is an infectious disease, has local environmental influences based on receptors, how the virus gets into the body, and there's symptomatic screening. But common to both is the socioeconomic disparity. We see this exemplified in COVID-19. Lifestyle factors that put one at higher risk for both of these diseases, as well as survivorship, medical, and socioeconomic issues. And what happened during the COVID-19 surge of 2020, that outpatient management of cancers was shut down. All patient encounters for cancer went hugely down in April of 20,000. New patient incidence for encounters for cancer went down for all types of cancers. And look at this, the screening for mammograms for breast cancer and colorectal cancer dropped as high as 85% for colorectal cancer and 89% for mammograms during that shutdown period. Now, here's the problem with that. This is data that we published recently, and is a take on Ned Sharpless, who is the NCI director, that looked at even a 6 to 12 month delay in restarting that screening. That's scenario A. So this is the typical screening in the population. The dotted line is if we continued on that trajectory. The dark line going down here is what happened during the COVID surge. And then the different colored lines are if we get back to normal. Line A is a 6 to 12 months delay. That would lead to, between breast and colon cancer over a 10-year period, about 10,000 excess cases with a stop in screening for this gap. If the delay was longer, so B, for 1 to 3 years, that could be anywhere from 1 to 5,000 annually. And if it took for several years, model C, 5 to 10,000 annually. This is horrific numbers if we don't get back to our regular population screening. The message here is don't delay preventive healthcare just because of COVID-19. Obviously, if you're positive and sick, it's not an emergency, but with excessive delay, we'll add the number of lives getting those cancers. Now, what about at-home colorectal cancer screening tests? Certainly mailing tests to patients to do at home is an option if they can't come into an outpatient center or a hospital. It is lesser in cost. The materials need to be mailed home, but still some will have difficulty in completing tests, and it may require navigation, much like that Delaware study. The provider or health system must follow up on negative and positive tests. A lot of people don't get information back that they have a negative or positive test. And even though you might have a positive test to mail home, it requires a colonoscopy, which may require additional navigation, depending on the person, their motivation, their insurance, and their ability to complete the test. And some patients still may be hesitant due to COVID-19. Also, I would say there's loopholes for screening versus diagnostic colonoscopy. That has been addressed by a number of societies, particularly the AGA. that loophole should be closing within a year. Whereas if you do a screening test such as a FIT, a colonoscopy, so if your FIT is positive and you get a colonoscopy, it's converted from a screen to a diagnostic colonoscopy. That diagnostic colonoscopy may have out-of-pocket costs versus a screening colonoscopy. So just to close, colon cancer is preventable. Let's all get screened. These are many people who, the year that they developed colorectal cancer, who have ultimately died if either from colon cancer or other reason. Chad Bozeman was the most recent, but Ruth Bader Gitters survived several cancers, including colon cancer. Sharon Osbourne, Elizabeth Montgomery, Clarence Williams III recently died this year. Both Audrey Hepburn and Ronald Reagan have had colon cancer. Eartha Kitt and the great Vince Lombardi also had colon cancer. Let me stop there and thank you for your time.